Good afternoon, everyone, and welcome to another session within the Young Advocate series. Firstly, I'd like to acknowledge the traditional owners in the lands in which we're all joining this meeting from, so that will be different for everyone. But for myself, this is in Gladstone and the Grang, and Baili and Bunda peoples of the land. And I would like to pay respect to the elders past, present, and emerging, and acknowledge that sovereignty was never ceded. This is and always will be Aboriginal and Torres Strait Islander land. So this brings us to, I think, one of the last sessions within the series. The aim of this series is to provide information that will be useful for young people in their work as individual advocates or as you work with the government, health services or community groups. The topics have been chosen by the Youth Health Forum Youth Leadership Group, which I'm pleased to be a part of. My name is Jasmine Elliott, and as I mentioned, I'm calling from Gladstone, but usually studying down in Victoria. So join with us today. We have two speakers to talk about the research process and how to have a say within it and after it. And those presenters are Dr. Rebecca Haddock from the Diebel Institute for Health Policy and Research. She's the director there, and Professor Tammy Hoffman, who is a professor of clinical epidemiology at Bond University. First speaking with us is Dr. Rebecca Haddock, and Rebecca is the director of the Diebel Institute for Health Policy Research, which is the research branch of the Australian Healthcare and Hospitals Association. If you haven't heard of the AHA, they are the peak body for public health in Australia. So they advocate for universal public healthcare and often publish really insightful reports about the healthcare system. Rebecca is internationally recognised for her work on obesity-related hypertension, has a PhD in neuroscience from ANU, and has held positions at several universities, including Oxford, and government bodies like the Therapeutic Goods Administration and the NHMRC, National Institute for Dementia Research. We have invited Rebecca to speak to us today about the research process, how the Diebel Institute identifies priorities and then translates these findings into implementable policy recommendations. Welcome, Rebecca, and we look forward to hearing about what you have to say.
Thanks, Jasmine. I'm just going to get my slides up. So as Jasmine mentioned, I'm the director of the Diebel Institute for Health Policy Research, and our main role there really is about connecting academic researchers and practitioners to policymakers so that we can embed evidence as a cornerstone of policy in Australia. And so I've been asked to talk about how we go about setting research and policy priorities. So when the AHA, or the Diebel Institute, thinks about setting policy priorities, there's a number of layers that we need to consider. So the first layer really is around the idea that setting policy processes, it's a really complex area, and it's actually inherently political. So the reason it's so complex is we have a number of stakeholders with different values and different missions and different objectives, and essentially everybody needs to compromise in order for policy priorities to take place. In Australia, the policy setting is determined by key objectives for the health sector over a given period, and you might have all heard of the 10-year health plans. So everything is really set around those, and they feed directly into the content of our National Health Reform Agreement. So that has recently, the addendum to that has recently been released, and so all our policy priorities are set to this document. And so in particular, we focus on the health reform sections, and so that includes things like health technology agreements, value-based healthcare, health literacy, preventative health and wellbeing, funding and planning at the local level. So they're all things that we need to consider when we're setting our policy priorities. And so I already mentioned to you, it's quite a complex kind of space. So on top of that particular framework, we need to consider current evidence that tells us that the ageing population, climate change, and increasing health inequities are also priorities that we need to be considering on top of the National Health Reform Agreement priority settings. So given that particular overarching framework, how do we set the priorities within our organisation? So we go about that in two different ways, and they're not separate, they're done in combination. So as I mentioned, it's a really challenging space to set a policy priority. So the first thing we might do is some background research, and in that we're looking for things like major risk factors. So that will be done through an academic literature research, and then that's in combination with, you know, we need to be looking through the grey literature to identify where policies that are currently in place and also where there are policy gaps. And so the thing that's really important to consider when you're setting a policy priority is that if you're really getting behind a particular policy priority and giving it, you know, really trying to get that advocated for, there's only a finite amount of funding within the system. And so, you know, somebody else's policy priority might not be funded, or it's going to suffer. So it's something to think about when you go about pushing for a policy priority. The other thing we really consider is stakeholder engagement. And so when we're thinking about stakeholder engagement, we look quite heavily at what government is thinking, and that might be through, for example, the Senate estimates committees. So they were held last week or the week before. So we will go through those and watch those quite closely around what policy topics they're talking about. There's stakeholder engagement more broadly within government, so at the Department of Health, other senior bureaucrats across government, within universities, other peak bodies, so lots of stakeholder engagement there. And then with that is also our membership engagement. So they might come to us with a particular policy priority that they want us to advocate for, or we will reach out to them. So the other thing that you really need to be considering when you're setting priorities is the role of the media. And so that includes being really widely read around the newspapers, so looking at the health sections, the politics sections, the television news, and the Twitter and Facebook, social media and LinkedIn. They're massive indicators of where the policy priorities are heading. And if you haven't got a Twitter account and you're genuinely interested in advocacy, I'd be getting yourselves a Twitter account. And of course, the most central thing that we think about when we're setting policies is the consumer, the patient. They really should be at the centre of everything that we're doing, because they are the end users of the policy and they're the ones that are ultimately most affected by what we are pushing for. So in a universal healthcare system, there's a couple of really broad policy priorities that are just standard. So it'll be things like burden of disease, effectiveness of an intervention, cost, acceptability, you know, fairness. So again, we've got another something to add to our sort of broad overarching framework. But then what we really need to do is to be narrowing down our focus so that we have a workable priority. And then, so what we need to do is be asking ourselves some questions that can help us narrow our field of interest. So, you know, is there strong evidence around a particular issue? You know, what will the impact be of addressing that issue? You know, how many people is it going to affect? You know, does it address existing health inequalities? And I think a really critical question that we ask ourselves on a daily basis is, you know, does our organisation have the experience and expertise to reasonably advocate for an issue? So, and if the answer is no, then we look for a collaborator that can help us provide that expertise, you know, to get our voice out there in a way that's considered trustworthy and you know, strong. So if we drill down to another layer, when I think about getting to design the research, I always myself and people I'm working with, we always start by thinking about what is the big issue? What is the big problem? And I'm going to provide you an example here around puppies. You know, do puppies have enough access to face masks? Okay, and so what is the end game around that? So, well, the end game that we want as an advocacy body is face masks for all puppies. Okay, but then when we're thinking about our research, well, how do we go from our big problem to our end game? So then we start drilling down into our issues that we are looking to research, okay? So once we start doing a bit of reading, we might find that face masks are expensive and wages for puppies are low. And the Department of Puppies has poor data on the number of puppies that actually require face masks, and the quality of face masks is variable. So now we have our big problem and our bite-sized issues that we can actually tackle. And sometimes we might come up with 3 issues and then drill down even further into one particular issue. And then that way you can sort of really supply the evidence that's required to address some of these policy gaps. One of the things I also do at this stage is actually start thinking about the tangible recommendations I want to be making around my policy priority. Okay, so this may seem like a really simple exercise, but it's something that I actually do with every brief that we put together. So the thing I would say is for every issue you've got, you really only need one recommendation. It doesn't need to be more complicated than that. So in this case, we've got add face masks to the puppy benefit scheme for low-income earners, introduce data collection on the use of face masks as part of the National Puppy Service, and standardise the pattern materials for face masks and introduce face mask regulations. Okay, so now we have a bit of a framework for our research that we can then go off and work on. So when we're designing the research, in order to get, to make a feasible policy difference and actually put together an advocacy strategy, the first thing we do after we've sort of mapped out our, you know, our overarching issue with our, and drill down to some individual issues, is it's around writing some key messages. So this is really around trying to identify what your sort of key issues are that you want to address and your recommendations. And so at this point, it's just sort of in a draft format. And then what we do with the key issues, and this is something that I think people always underestimate how long it actually takes to do. We spend about a week on these. They do require a bit of research behind them. You can't just go off and say, this is the problem and these are the recommendations for fixing it. You actually need a bit of solid evidence behind them, but they are only draft at this stage. The next step is we actually do quite a lot of stakeholder engagement around these key messages. So in this particular instance, which was a brief we recently published on optimising healthcare through specialist referral reforms, we engaged with members of the Department of Health. We talked to the RACGP. We talked to some law academics at the University of Newcastle. We engaged with the Consumer Health Forum, and of course we have in-house expertise at the Australian Healthcare and Hospital Association. So the next step really around that then was refining our key messages. So we take on board the stakeholder feedback. At this point, you don't have to agree with everything your stakeholders say. You just need to acknowledge their points of view. Because ultimately, particularly with government, they're the ones that you want to implement your recommendations. So if they say, oh, we won't recommend, you know, we would never implement that recommendation, then don't go ahead and research it. It's a waste of your time and a waste of the government's time, because they will literally just bin your documents. So as I said, keep refining your messages. It's a continuous process right through to when you're ready to publish. Be really flexible. I think that's key. As I said, if a policymaker says, oh, we won't support that, change track, find out what they would support and go down that particular avenue. With a policy document, they're not literature reviews. It's really important to just find those key documents that support your argument, as well as if there's some that oppose it, they also need to be presented as well. When you're designing the research, always seek feedback, always engage with stakeholders. It's never criticism, and it's always about crafting a really strong policy document that you can use for advocacy once it's finished. So lastly, when we think about translating our research into policy and practice, I just want to make a really strong point that it's not actually the end point that you start translating. It's actually right from the beginning, right from when you're thinking about your key messages, the gaps in the policies, the issues affecting consumers, and then that carries through the document. Constantly engaging with stakeholders around the issue, seeking feedback on the drafts, that's all part of the research translation process. And if you leave it to the end, you won't successfully able to translate your policy documents. And so an example I just want to provide you with is again around this brief we recently published on specialist referral reforms. Is once we published that, we also published an accompanying article in The Conversation, and that actually received over 67,000 hits. It obviously had a very strong emotional pull with the general public. Lots of people have had issues getting referrals, and having been sent back to doctors. It's a waste of time, it's a waste of money. But the really interesting lesson that we learned from this particular piece of research translation was the accompanying piece is very short, it's very light on evidence, and it struck a nerve with the RACGP, who came out in quite a force opposing the article without having actually read the policy brief that sat behind it. So I think the takeaway message from all of this is make sure that you have strong evidence to back up your issues and your recommendations, and that's just a really important message when you're doing research translation. So I think that's my time, and I'll leave it there. Thank you.
Thank you for that presentation. We'll be returning to questions at the end. So if you are watching this webinar and have a question that you'd like to ask either Rebecca or Tammy, please put it in the chat or the Q&A function. That would be fantastic. But we'll move on to the second presentation, which is from Professor Tammy Hoffman. Tammy is a professor of clinical epidemiology at the Institute for Evidence-Based Healthcare at Bond University, and is also an NHMRC Senior Research Fellow and Co-Director of the Australasian Equator Centre. Her work has researched different elements of evidence-based practice, like shared decision-making, knowledge translation, and minimising waste in research. Tammy has been involved in the development of reporting guidelines and templates to improve reporting, and has encouraged the uptake of effective non-pharmacological interventions. We have invited Tammy to speak with us about what evidence-based practice is and how it looks when it's implemented in a healthcare service, what data is currently being collected and how it is used, and how we can use it ourselves to understand and talk about issues like overdiagnosis. So without further ado, I'll hand over to Professor Tammy Hoffman to share her presentation.
Thank you, Jasmine. Let me just share my screen. And then, okay, it's saying you can't start screen share while another participant is sharing.
Yeah, so I think Dr.
Rebecca needs to. There we go. Let's try that again. All right. Okay. So as Jasmine said, my background is anything to do with evidence-based practice, right through from getting clinicians to do more efficient and rigorous syntheses of evidence, through to reporting them more completely, to reporting them in a more usable way for both clinicians and patients, through to issues to do with what's the best way to communicating evidence to patients, how do we involve patients in informed decision-making more, and everything around all of those things. So in the 10 minutes or so that I was going to talk today, I'm just going to touch briefly on two things that a quality healthcare system needs more of. My talk will be much more at a, I guess what we can do at an individual level to do these things rather than at the policy level like Rebecca's talk. But knowing about some of these issues in an advocacy role is going to be important as well. So hopefully you can see it on both sides of the coin. So two of the key things that a quality healthcare system ideally would have more of. One is research evidence. Surprisingly, a lot of what we do is not based on evidence, or certainly not strong or high quality evidence, and incorporating patient preferences much better than what we do. There's some terminology that's emerged in the last few years about appropriate healthcare or the right level of care, and it's a nice way of sort of summing up some of these issues. The problem is we do, in the healthcare system in general, is that there's a lot of overuse. So a lot of people receive tests and treatments that are not that beneficial, and the benefits don't necessarily outweigh the harms, and perhaps it's something that people don't need. And then the other side of the coin is we have underuse, where there's a lot of effective treatments that a lot of people miss out on for various reasons. And so we need to be in trying to improve both of those. And reality is, and a lot of people don't realise, is that most healthcare falls into this grey zone where it's not that something is clearly superior or better than another option. There's very few examples of that. And it's at the other end of the spectrum, it's not that there's a lot of interventions that are woefully harmful and have no benefit. It's usually that the balance of benefits and harms is variable because we either don't have enough research to be sure, or because it depends on the subgroups of the populations or people's characteristics, or people's preferences and their values and what's right for them and their circumstances at that point in time. So trying to provide healthcare that is just at that right level of care for the right patient at the right time is an enormous challenge, and one that I think is going to face the healthcare systems for many years to come. So for those who aren't familiar with what we mean by evidence-based practice, it's a term that gets bandied around a lot, often incorrectly. So just so when I use it, you're aware of the definition. It's when a clinician takes information from four sources. So one from their clinical expertise, another source of information is what's in the research evidence, another is what's in the practice context, so the practicalities around where they're working, and then finally information about the patient's values and circumstances and preferences. And so evidence-based practice is when information from all four of those sources is come together at the time of making a clinical decision. Okay? Traditionally, when we teach evidence-based practice, we talk about the 5 steps of it. So this is what clinicians are taught to do. So step 1 is to ask the clinical question. So where's the evidence gap? Usually, ideally, when you've got a particular patient in front of you. Step 2 is to go search for it, search the medical literature. Step 3 is to critically appraise it. Quite a lot, overwhelmingly, the majority of what's published is poor quality, is quite rubbishy, and the conclusions can be disregarded. So you need to critically appraise it and sift through to get the good quality evidence that's remaining. And then step 4 is about applying it. How do you actually discuss it with your patient, integrate it into a decision-making process? And then step 5 is a reflection on that how well a clinician felt they did that whole process. So step 4 there is the one that's had the least amount of attention in terms of EBP, so there's almost 2.5 decades of literature now on evidence-based practice and what it is and how to teach clinicians and how they should do it. And the step that's had very little attention until recently is this step 4 of applying it to the individual patient sitting in front of you. And so that's the one where we're trying to advocate to make that get much more attention. And the process by which that happens is something called shared decision making, which I'll elaborate on in a minute. So we wrote a paper a few years ago where we'd had this sort of realization that there's all this stuff on evidence-based practice or evidence-based medicine, and all this stuff on how to communicate with patients, but it's actually where those skill sets from a clinician's point of view come together that you're doing shared decision making, and that's what we need for optimal patient care. So shared decision making, It's where a clinician and a patient jointly decide about what decision is going to be made from the problem that's facing them. But it comes after there's been a discussion about what are the options. And there's always, nearly always, the option of do nothing. Might be a wait and see option, might be various test options, various treatment options. Each of those options has benefits and harms, both in terms of so quantitative benefits, and this is what we get from the research evidence about how much benefit you're likely to get, you know, how many people out of 100 will experience an improvement, and also harms, how many people out of 100 who have this treatment might experience a side effect. But also practical information like the cost of the options and the practicalities, like does it mean going in to see a doctor once a week for 6 weeks versus another option that doesn't involve that. So it's all of the issues to do with the options, the benefits and harms or pros and cons of each option. And then also what matters to the patient, what's important to them, what's their preferences, what's their values. And it's about having that conversation and tying all those ends together. So I thought I'd finish up by just touching briefly on 2 examples of ways to encourage patient involvement in healthcare decision-making. The shared decision-making that I talked about, we've been doing some work trying to encourage it from the clinician end. So how do we get it into guidelines? How do we train medical students and clinicians in shared decision-making? But there's also, from the patient side of things, these are some questions that patients can ask in a consultation or, you know, posters in waiting rooms to actually trigger that conversation when they're meeting with their clinician. So it's what happens if I wait and watch? What are my options? What are the benefits and harms of each option? How do the benefits and harms weigh up for me? And do I have enough information to make a choice or make a decision? So even though we're trying hard to sort of get clinicians to routinely do this, that's going to be a long time coming. There's certainly things that patients and the public can do from their end to trigger that. And then the other much broader issue that we're trying to tackle is improving health literacy around the need to think critically about health claims and how that might feed into improving decision making. So we've been doing some research with some high school students, actually teaching them about how to spot health claims around them and how to think about what's the research behind that health claim. Is there any evidence to support it? A lot of the time it's not, because we know teenagers are seeing things, you know, on social media and on the internet, and they're often haven't ever stopped to think, oh, I wonder if that's actually true. So I thought I'd just share a few slides about what we're covering in that. We're currently doing a randomized trial in high school students. So we've talked to them. It's a four module program, but we show them like some of these headlines that you see in magazines or in newspapers, and we get them to think about, do they believe them, and if so, why, and if not, why not? Get them to just stop and actually think about the believability of such claims. Introduce them to what a health claim is, which is any statement about an intervention and outcome, and think about what types of information would you need before you could reliably make a health claim. So there's all those social media kind of ones, but then there's also ones that appear in the literature. So when you see these from the medical research itself, and it's contradictory. So about echinacea, one press release says it can prevent a cold, one says it doesn't treat colds. Same thing with screening for prostate cancer. You've got 2 articles, both in New England Journal of Medicine, one saying it reduces mortality, one saying it doesn't. So it's not just magazines and social media where you're getting these contradictory claims. It's even in the health research. So having the skills to stop and critically think, well, what type of research was it? Is it quality research? Should I believe it? So the program that we're using, it's called Health Hack, How to Assess Claims Critically. We take students through things like danger words to look out for, like breakthrough, miracle, cure. We talk to them about how the word's scientifically tested, evidence-based, clinically proven, tested in clinical trials, all those things you get often in small print on products, that anyone can put that on a label, and they do, and they doesn't mean anything in particular. There's no standards they have to adhere to be able to use those phrases. We talk about endorsements and anecdotes, obviously not being reliable, association and causation certainly not being the same thing. There's some exercises on that. We point out the difference between observational studies and experimental studies, and that there's only one study type that can start to prove causation, and that's a randomized controlled trial. And the students do an activity learning what a randomized trial is and why that balance between groups is important. We talk a little bit about systematic reviews and not believing one study and wanting ideally to see it replicated in multiple studies and then synthesized. And we get them to think about what makes a fair comparison. So when an intervention is being tested, ideally we'd like to see it compared to something else, and was it done in a fair way? Is there enough participants? Not being misled by relative risk numbers in press releases and news articles, but actually looking at absolute numbers, and we break that down for them. And then thinking about how does this apply to whatever decision they might be facing. So the pros and cons, or benefits and harms. And that's it. So I thought I'd just share with you just a few of the ways we could try to get more research evidence into our healthcare system, both from clinicians, from patients, and also broader public awareness of health literacy and the quality of health claims.
Fantastic. Thank you both for the presentations. I think it's kind of shared two different aspects of the research process, I guess more macro in terms of policy, and then downstream to the patient individually and the doctor in that setting. So we do have one question in Q&A, and we also have some questions that have been sent to us prior to this webinar. So I'll just start with one that I guess applies to both of the presentations. In both of them, we kind of learned how important research and evidence is, and how numbers are important to advocacy, and then also when making shared decisions. But on the flip side, it can be tricky when people don't necessarily understand those figures or understand the research. That might be a politician, or it might be a doctor who doesn't necessarily have grasp of those critical appraisal skills that you talked about, Tammy. How do we go about advocating in these situations, and what sorts of strategies do we need to be looking at in the future?
So one of the things we've been trying to research is what's the simplest way and most understood way of communicating some of those numbers, and how can you distill it down into really easily digestible chunks. And what we found is that you can simplify it to absolute numbers and natural frequencies, which patients and majority of the public understand, and that clinicians also like it like that too. And so do politicians and policymakers, because it's easier for everyone to understand. So it's certainly, we've got to get away from this, statistics are scary and hard to understand. There are absolutely ways to do that, and look at the best graphics to communicate it. Is it bar graphs, or is it line graphs, or so there's quite a lot of research around how to do that, and I think the more that we all adopt those principles, the better.
Rebecca, did you have anything to add? Sorry, I think you just unmuted.
Couldn't unmute myself. You'd think after all this time we'd have it down pat. I absolutely agree with everything that Tammy said, and I just wanted to add that when we're working with policymakers, we tend to sort of use data quite generically, in that within the body of our research, we actually remove a lot of the hard numbers and place them out in appendices, or make them, like, let the policymaker know that we have them available. When we're writing for policymakers, we use things like around 1,000, nearly 100 years ago, over 10 million, because once you start using that really sort of complicated hard data, you just lose the policymakers. So it's kept quite generic, particularly in the key messages. I think that's the place to keep it quite generic. You can put data into your work, and if they're interested, they'll contact you for that harder data. But it's important to have it. That's the main thing.
Fantastic. So we'll move to the question and answer box. Rebecca, about your presentation, we had Kathy Dallas, thank you for joining. Can consumer groups ask questions directly to the Diebel Institute?
Yes,
so I guess it's about engagement.
Absolutely. You've got my contact details. You can, quite happy for you to forward them on.
Cool. And the second question was with regards to Tammy's presentation. So it's from an anonymous attendee, but there are a few different university health and medical degrees that would benefit from your current work with regards to the Healthy Hack program within the high schools. Is there any potential to apply this at a tertiary level?
So I guess if it's for clinical degrees, so for health professional degrees, then what we're really teaching is a simplified form of evidence-based practice. We're teaching the very basics of that to students and the public. So hopefully all clinicians, we know that most clinicians get evidence-based practice taught throughout their degree. It's a requirement of most health professional degrees. The quality with which it's taught is variable, but yes, certainly they should be getting those concepts through evidence-based practice. Once our trial is over, we're very happy to make all our materials freely available to whoever wants to use them in whatever context.
Fantastic. Yes, no, I have fond memories of my evidence-based clinical practice.
Good. That's good. It is when some students go, yeah, I think I learned about it, but I'm not sure. You think, okay.
Fantastic. Well, that's all we had in the chat, but we'll return to some of the previously sent in questions. I guess we talked about, Tammy, in your presentation, how the doctor can engage a consumer with regards to shared decision making and sharing evidence with the patient themselves. But I guess if we flip it over and a consumer's been doing a bit of research as a patient, what is the best way for them to interact with the research fields to inform their choices? And how do they bring that to a doctor who might not necessarily agree with what they've found?
Yeah, so I think there's been a lot written about this, because I think patients are very good now at doing Dr. Google and bringing in something and said, I read this and I'm sure this will help me. So, I mean, one of the first things is hopefully that patient has a good relationship with the clinician. I know with general practitioners, that's often the case. Hopefully it's a long-standing sort of relationship with rapport. It can be trickier with an initial meeting with a specialist. But what we're trying to do is equip the clinicians to have the skills to incorporate whatever treatment, and sometimes it's a really non-traditional treatment. It might be something crazy they found on the internet that's got no evidence. Hopefully the clinician has the skills to go actually look at that website or that claim and say, okay, so it looks like they've tested it in 4 patients. We'd actually need to see it tested in a bigger group of people and compared to something before we could know it was right for you, and incorporate that into a more structured kind of shared decision-making consultation. But absolutely, it shouldn't just be dismissed as, okay, well, that's not right. That ideally would take the time to look at why that claim, which can sound so promising and so wonderful, isn't probably not all that it's stacked up to be.
Fantastic. So then moving to another question, we had a previous webinar with someone who was also involved in research, and they found that a lot of the young people's priorities that they had with regards to research were initially being, I guess, struck down by ethics committees before young people had involvement, and it was things around sexual health and priorities and things that they really wanted to have research done, the young people, but ethics committees and other groups involved in setting those priorities kind of identified that young people were too vulnerable to be involved in that research, or that they wouldn't benefit from having information about sexual health or the particular questions that young people were advocating for. How do we get consumer groups' priorities heard in the research space, particularly young people, in order to shape some of the advocacy?
I can't speak specifically to ethics committees, but I would suggest, as you said, engaging with consumer groups who then provide a stronger voice when dealing with researchers, amplifying the message for you. That might be one avenue of allowing younger people to engage more in advocacy and research.
Yeah, and I think also in trying to engage in the formal kind of priority setting processes like the James Lind Alliance that's emerged over the last decade or so, which is a very structured way of working out for particular conditions and particular groups of people what the priorities are, and that provides a really rigorous way of saying these are our identified priorities. And I think that can reassure people who might think, well, where did these priorities come from? That it's actually, there's been some research behind identification of the priorities. So I think trying to engage and collaborate with people who've got expertise in something like those James Lind processes is valuable.
Yeah, there's also a group called the Hales organisation, and they're quite involved in sexual education and women's health and things like that. So, like I said, engaging with peak bodies that can amplify your voice might be one mechanism.
Fantastic. Another question has come through in the question box, and it's from Claudia asking, why do you think that patient preferences have only really come to fruition in the last few decades?
I'm guessing that's aimed at me. I think it's a very slow move away from that traditional paternalistic view of healthcare as doctor knows best and doctor is right. I think it's only in the last sort of decade or two that there's been that recognition that doctor or any clinician often not only doesn't know best, but often doesn't know, because there's that uncertainty, and it's not just opinion-based medicine and evidence-based medicine. It needs to be grounded on evidence. There's been some criticism of EBP over the last 2 decades saying, oh, it's just cookbook medicine and ignores patients' preferences. But if you go back to that original definition, that 4 circle diagram I showed you with the Venn diagram, it's always had patient preferences and values right there from the get-go since Gordon Guyatt coined the term. But that's been the bit that I think everyone got really excited about, the research evidence bit, which is important, but the bit about patient preferences got ignored. It's only now that we're starting to look at how do we bring that into the equation, bring it into the decision-making, how do we elicit patient preferences, how do we accommodate guidelines so that they reflect that, and how do we help clinicians to think to do this. And yeah, so I think it's just all part of the very slow movement away from doctor knows best paternalistic thinking, but we're getting there. There's been quite a lot of change in the last decade or so.
Can I also make a comment on that? I think from a systems level, there's also been a shift to more sustainable funding model, and that is value-based healthcare. And with value-based healthcare, we're looking at outcomes over cost and putting patient at the centre of care. And I think from a systems perspective, as we start to shift from the user pays, the fee-for-pay model, and more towards the value-based healthcare, I think that is also putting patient preferences and patient outcomes more at the centre of our care models.
Fantastic. Thank you for those insights. Another question we have, maybe more targeted towards Dr. Haddock's presentation, but Tammy, you might be able to answer it as well. So you mentioned having to work a lot with governments in terms of guiding research priorities with regards to funding, and then the recommendations as well. You mentioned that their perspective on the feasibility of recommendations affects the feasibility of the research to begin with. Yep. How much do you find that changing governments affects the research space, and is this an obstacle for you?
Well, it can dramatically change the research space because governments often shift priorities. They have different values that they want to progress. But in terms of our particular organisation, it doesn't change how we go about researching or what we're presenting or how we interact with government, because we are non-partisan, so we don't align particularly strongly with current government or opposition. So I think that's a really important role of peak bodies, is to remain non-partisan so that you can be seen as a trustworthy source of evidence when you're progressing your policy initiatives.
Fantastic. Tammy, did you have anything to add in that space?
I think Rebecca answered that beautifully. Perfect.
And then on that note, I think both of you might have experienced this, and something that I've heard a lot about is how do we ensure that, the less sexy, so to speak, research topics do get covered in research, and that the results after that avoid the publication bias at the end when the media might not be as interested in a negative finding or something like that.
So, I mean, I think a lot of what I do is considered unsexy and doesn't get funded. So we try to find, I don't do drug trials, I don't do vaccine trials, for example. I do all the non-drug stuff and how to talk to patients, and it's hard to get funding for that stuff. So we try to be creative with doing things with very little funding and being very efficient. But I think trying to adopt an open science policy where you make everything you do available these days with open science framework and registries where you can deposit all your research materials and all your findings and all your results and all your protocols and templates and data. Even if you get a negative result and it's hard to get it published in a traditional journal, then there are certainly ways around it, even with no funding, of making sure those results are available. So I think transparency and open science, which is a parallel movement that's happening, is important.
So I think there are lots of subjects that aren't considered sexy, but I think the important thing is if you can find an evidence gap, then government will listen, particularly if we then think about the frameworks I talked about in terms of the National Reform Agreement and the addendum to the National Reform Agreement. If you can align your evidence gaps with one of the policy priorities that government is interested in, then they will listen. So they're not a lost cause, they can get funding. It's just about thinking strategically and actually recognising that government has set priorities that they are going to fund. So how do you align your particular body of work to those particular priorities? And it is doable.
Fantastic. It sounds like a lot of creativity might come into play with.
As long as it's evidence-based.
Yes, perfect. I guess moving on to another question, and it kind of plays into the funding, but also I guess having different organisations, different universities, different individuals involved in the research space, we can see different people doing very similar projects or working on very similar issues. What kind of opportunities do you as organisations have for collaboration to, I guess, minimise some of the over research that we might see in areas such as say youth mental health or you know, in the COVID pandemic, the many people searching for a vaccine?
Yeah, I mean, this is one of the big problems in the waste in research stuff that we do is, and we actually wrote an editorial in the BMJ about wasting COVID research because it all got sidetracked by small studies, poorly designed studies that got a lot of media attention, and then a whole lot of Me Too studies, a whole lot of duplicative studies that ended up just wasting hundreds of millions of dollars. And there's a whole lot of neglected areas, interventions that weren't getting funded. There's no easy answers for how to avoid duplication of research. I mean, there's been some initiatives to try to avoid it, like registering your systematic reviews on things like Prospero. So ideally a researcher would go and search, is somebody else already doing this, to check. And when you write research grants, we're trying to lobby NHMRC and other funders to actually require that a systematic review has been done before a trial is proposed, because a lot of the time a trial or something very similar has already been done. So there's little initiatives along the way, but ultimately it comes down to the responsibility of the researcher to be a responsible member of the scientific community and actually look for those gaps, be confident they're truly addressing a research gap and not just jumping on another bandwagon. Yeah, I think we could advance our knowledge a lot faster and a lot further if we reduce some of the duplication.
And piggybacking on what Tammy said, which I completely agree with about there's a level of personal or organisational responsibility for not duplicating work. So a key thing really is also around, for policy research, is around that stakeholder engagement. So often when you go to those early conversations, they often will mention another group or another organisation or a university that might be doing some similar research. Then you will set about collaborating or backing off if the case, you know, needs to be. And the other thing I wanted to know is often when we go up and see Minister Hunt with some policy work, he will often say, so-and-so is doing similar work, you should collaborate. And that's, he's all about collaboration. So that's something that we strive to do. It's really important that you know the landscape and don't duplicate, because it is ultimately a waste of taxpayers' money too.
Fantastic. Well, we might ask one question to wrap up, and it's a fairly broad and potentially tricky one. But what is the most exciting or the most influential project that you've been a part of during your research experience, and why is that?
Well, I can speak to some of our more recent work. We often have really exciting outcomes from our policy research. So we've had a paper in 2018 on at-home care packages and aged care, and that got fed into the Royal Commission on Aged Care, and that was quite exciting. We had another policy brief on kidney disease and housing for Aboriginal renal patients in the Northern Territory, and that got a pilot study funded by government. We have another paper that was on discharge against medical advice in Aboriginal populations. You know, that was picked up by government. So we actually get, and there's, you know, probably quite a few more, but we actually get tangible outcomes from our policy work because we've already had that stakeholder engagement that tells us what we can and can't achieve. So always good to have blue sky thinking, but also some small steps that can get some policy wins and your initiatives on the table as well.
I think I've got two examples, and I was just reflecting on it while Rebecca was talking, and ironically both of mine, probably the things I've been involved with that have had the most impact, I just realised neither of them had any funding whatsoever. So we've just sort of done it on the smell of an oily rag, it seems like. But one of them was a series of projects, like a dozen projects, that we realised that the way that randomised controlled trials are reported, that the interventions aren't reported in enough detail, that if a treatment's effective, the clinician actually doesn't know how to use it. So even for drug information, you need to know the dose, you need to know the route of administration, that's usually there. But for non-drug interventions, which is about, so that's everything else, which is about 40% of all randomised trials, if you don't know what the procedure was, what the dose was, what the setting was, what the materials they used with the patient, you can't actually deliver that. And it's a huge gap to getting evidence into practice. So once we'd done some research to show that that was the case, we developed a reporting guideline called Tidier, which is about getting, describing interventions better. And in about 6 years, that's had over 3,000 citations. It's now required by Cochrane. It's in the new PRISMA statement. It's in lots of journals require it. So that's, I think, actually helped clinicians be able to use interventions, evidence-based interventions more, because they've had the details of what an intervention actually looks like. So that's been very satisfying. And the other one is about shared decision-making. We realised when we wrote that paper in JAMA about getting EBM and shared decision-making together, one of the big barriers to shared decision-making is a lot of clinicians think they already do it because they've got good communication skills. And then we thought, well, how do we help them develop the skills in shared decision-making? And there's no workshops. There's very few workshops you can go to, particularly in Australia. So we developed a module in conjunction with the Australian Commission of Safety and Quality in Healthcare, a 2-hour online interactive module that takes clinicians through what is shared decision-making. And that has had enormous uptake. We've got, it's been endorsed by lots of colleges here, both over in the UK. It's endorsed by 5 Royal Colleges. It's got different worked examples and videos of different specialties. It's all free. So I think we've had thousands and thousands of clinicians now be able to just do a 2-hour online shared decision-making course and get a little, it's not perfect, it's not going to make them superstars at it overnight, but it helps them to be aware of what it is, to feel more confident, have some of those skills to have those conversations with patients. So that's, the uptake of that's been really rewarding as well.
Fantastic. No, it sounds like both of you have done some really influential things within your careers so far. And yeah, thank you again for sharing your experiences and your insight with us as a part of this webinar. That brings us to the end of the questions. So once again, thank you for your time. This is the last webinar, as I mentioned earlier, in this series, but they will be on the Consumers Health Forum YouTube channel soon. So if you want to go back and watch earlier presentations, you can if you missed one. Otherwise, I'd really like to thank Origin, who supported this webinar, and to the Consumers Health Forum for their continued support of the Youth Health Forum. If you'd like to know more about the Youth Health Forum itself, please get in touch with Carolyn. She's put her email address and contact details in the chat now, and it's also on the event page if you do miss it and need it later. Thank you both for your time. Thank you to Carolyn for getting in contact with all the amazing speakers that we've heard from in the webinar series, and enjoy the rest of your evening to everyone who joined the webinar.
Thank you.
Thanks so much.